So hi, everybody. Welcome to Congenital Heart Academy and CHIP, and we are very happy to have this amazing session today with very good panelists debating two papers very interesting about the Fontan operation at high altitude. Before we start, I just want to ask you again to follow us on social media and subscribe to our YouTube channel. There you're going to be able to see what we are planning for the next couple of weeks. And if you like this presentation and you want to share with your team, please share the link on YouTube so everybody can learn more about this topic. Just to remind you guys that we're having the Dr. Anderson series, and the next meeting is going to be on the 15th of September. It's going to be very nice. We have a lot of people presenting with him, and we have 3D images from Justin. We have the anatomy pieces from Diane. So it's been a very nice series. Please join us. And on September the 30th, we have Dr. Mary Cohen talking about intraoperative TEE. So this is going to be very nice. And we just want to let the surgeons in-house to know that we still have this very nice initiative from Sick Kids about hands-on on the 3D printing models for congenital heart disease surgeries. Please take a look on their website. This is a very nice opportunity for the surgeons. And for all the providers involved with congenital heart disease care, we have the Sick Kids Advanced Pediatric Cardiology Program. It's almost 1 year program of learning. So take a look on the website as well and get more information. And now I'm going to share with you a video about the World Congress. Dr. Gary is here with us today, and he's going to talk a little bit about it. If you want to have more information, please scan this QR code. And this is going to lead you to our website, or you can just type this website address, and then you can have more information. Please subscribe to the newsletter of the World Congress, and then we're going to share with you more information about what we are planning for you for next year in Washington, D.C. So I'm sure this is going to be amazing. Now, Dr. Gary is going to tell you more about it.
Good morning, good afternoon, good evening, wherever you're from. My name is Gil Warnofsky. I'm a pediatric cardiologist and a cardiac intensivist. I'm in Children's National Hospital in Washington, D.C. And I was thinking as the video was running that if I could think of two things that I'm most proud of and happy about in my career, it's to have been one of the co-founders of the Congenital Heart Academy, which has really taken education, which might have really fallen apart during the pandemic, to a whole nother level globally. We've had about, I don't know, Grace, what about 28,000 unique visitors these days, and from about 107 countries that never would have had the opportunity to make it to an international meeting. So that's been terrific. And then speaking of international meetings, the USA got the bid to hold the World Congress in 2015. We were planning to have it at 2021, but because of COVID, have postponed it. 3 days ago was 1 year away. So we're just about 1 year away from the World Congress. We have a plan for a 4.5-day event, about 800 faculty, probably 1,500 posters, and a poster competition, abstract competition. Many. I'm going to show you the program at a glance in just a second, but we're very, very excited about it. There's a QR code that Grace showed. Our web address is on there. What we're particularly proud about is we've made a very concerted effort to make this global. Attendees from low and middle income countries will have a substantial reduction in the costs, the registration fees. On our website is now a invitation letter to start your visa process. So you can log right onto our website now. And I know that for certain countries, visa access is so challenging. So there's an invitation letter that can be personalized for you and get you a visa, hopefully, before the World Congress starts. And I know how difficult that is. There's going to be a large global participation, sort of just like what we're doing here. So now let me just share one quick thing with the program at a glance, and then I'm going to turn this over to Sharmil for the rest of the features. This is our program.
Gil, if you can unmute yourself, we can listen to the music.
I think I've listened to that music about 150 times by now. So we haven't announced our faculty yet, and we're in the process of finalizing that. But I'll give a sneak peek that one of our featured landmark lecturers is on this panel today, Dr. Nestor Sandoval. So congratulations to you, Nestor. We're really very, very happy that you'll be joining us in that regard. Thank you.
Thank you very much, Gil. Thank you very much, everybody.
It's really our pleasure.
Pleasure to be here.
Of course, it's a secret, so nobody's allowed to tell anybody. Okay, excellent. So I'm going to turn this over to Sharmil. Dr. Khanna, you are, what time is it where you are, by the way?
It's 6:30 in the evening, Dr. Vinovsky.
Oh, not so bad. Okay. So we have two great papers to discuss today, two great approaches, somewhat different approaches. and some panelists with expertise in a variety of things, including pulmonary hypertension and Fontan's and congenital heart disease and ICU and surgery in general. So I'm going to turn this over to you, Sharmil, and I hope everybody can take a look at our website, start your visa application, and we hope to see you in August of 2023. Oh, Grace, I forgot to mention that the Congenital Heart Academy is one of the 4 educational partners of the World Congress of Pediatric Cardiology.
And we are very
surgery.
happy for that.
Not that I know people, you know. Sharmil, it's all yours.
Thank you very much. On behalf of Congenital Heart Academy and myself being part of CHIP Network, I welcome you all for this Dr. Gary Webb Memorial Journal Club that we conduct every month. Today we have 2 very interesting papers to be discussed about the effect of high altitude on the Fontan operations, how this altitude affects their post-operative care, and what are the long-term results of this, what are the effects on the long-term results of the high altitude on the Fontan operations. We have 2 different approaches. The primary paper that is going to be presented is by Dr. Alistair Thomas. He is himself a 3rd-year resident from Fortis Mohali in Punjab, India. And the second paper is by Professor Macedo, which is discussing the non-fenestrated Fontan operations at the high altitude. We have great panelists today. It's my pleasure to introduce my own mentors, Dr. Reena and Raja Joshi from my institute. And I forgot to introduce myself, as usual. I'm Dr. Sharmil Khanna. I'm a 5th-year resident from Sir Gangaram Hospital, New Delhi in India. And I've been part of CHIP Network for a long time, since Dr. Gary Webb was there. And it was his idea that education should be freely and freely available to all. And with that motto, the CHIP Network and Congenital Heart Academy joined. And I believe it was the idea of Dr. Gary Webb as well as Grace here to start this journal club. And after he passed away, we started off with this journal club, and we have been going strong. Without taking much further time, I would hand over the platform to Alistair Thomas. Alistair, can please go ahead and present.
Thank you. Thank you for the introduction. First of all, this is hello to everyone, and it's very overwhelming for me as a 3rd-year resident to be presenting a paper when the author is also present here in front of people who have made a huge impact in the field of cardiac surgery. So without wasting much time, I would like to start my presentation. I'll just share my screen. So I hope you can all see. So this paper by Dr. Nestor Sandoval, who is here as a panelist at the meeting. So I will be doing an article review of this paper. So the title of this paper is 2,640 meters closer to the stars, does high altitude affect Fontan? This was a wonderful study that I felt would be an ideal discussion topic amongst, especially in this day and age, especially when we know that the results of Fontan can be made more better. And if there are any other factors, here we're looking at altitude, but if there are any other factors, or what all are the risk factors, or what all should we look for after Fontan surgery, which could alter the course of the further course of the patients and their response to the surgery. So, just a brief introduction. The Fontan-Kreutzer operation was first introduced in 1971 as a palliative surgical technique for tricuspid atresia, and now it has become the standard of palliation for most of the patients with single ventricular physiology. The thing about Fontan is it produces excellent and reproducible results in terms of morbidity, mortality, and freedom from re-exploration. And the thing is, as I mentioned earlier, there are multiple factors that influence the short and long-term results of this operation, and we are still still exploring these many factors. So the factor that we would be discussing more in detail, or what we'll be looking at more in detail in this paper, is the effects of higher altitude on Fontan, and the results in these patients when they lived in a higher altitude in comparison to those who underwent the Fontan operation and who lived in subsequently lower altitudes, if there was any difference as such. So as we know, high altitude increases pulmonary arterial pressure and pulmonary vascular resistance. So this was the question that was posed while following through with the research. And the question was, will high altitude affect Fontan results? And what is high altitude in the first place? So most physiology articles, so they consider any altitude above sea level of 2,500 meters as high altitude. Children with cyanotic heart diseases at higher altitudes will definitely be more hypoxic and are prone to development of pulmonary hypertension. So what did this study aim to look at or to evaluate? So one was to look at the or to evaluate the results of the fenestrated Fontan operation at high altitude. So in this study, we'll be talking about the usage of fenestrated Fontan operation, which was done consecutively in 104 children, cyanotic children, who required the procedure. The second aim of this study was to determine if a difference existed in the functional class between patients living at low altitudes and versus those living at higher altitudes. The materials and methods. So this was a retrospective study for around 16 years, from June 2003 to February 2019. And 104 patients received the fenestrated Fontan operation at Fundación Cardioinfantil La Cardio in Bogota, Colombia. Forgive me if my pronunciation is wrong. You can correct me later, Dr. Sandoval. So how the data was collected, or what they looked at. So it was all from the International Audited Pediatric Cardiac Database. So all the variables, the operational definitions, the pre-op, post-operative characteristics were all taken from this cardiac surgery database. And in the study, patients were divided into two groups. So the first group of patients involved those who lived permanently below 2,500 meters above sea level. And the second group is the one which we are focusing on right now, are those who permanently live at an altitude greater than 2,500 meters above sea level. So the interventions, how the surgery proceeded. So all surgeries were performed using a CPV with mild hypothermia. The choice of Fontan technique and the use of cardiac arrest were all decided by the operating surgeon. And all the patients, they received a 5 to 6 millimeter large fenestration. And since 2005, in the extracardiac conduit has been the procedure of choice with the use of PTFE tube grafts. And the sizes of these tube grafts varied from 16 to 22 millimeters. And so the fenestration was created in the conduit itself, and there was a side-to-side anastomosis done to the right atrium, as classically described for fenestrated Fontan. And in these patients, temporary pacemaker bipolar leads were also implanted in the ventricle and the atrium for arrhythmia control. Now, in the post-operative phase of these patients, so after surgery, all these patients were taken to the pediatric ICU. The main focus was early extubation, prevention of arrhythmias, analgesia, and bleeding control. For patients who had higher preoperative or postoperative pulmonary artery pressure, in the initial part of this study, they were initially managed with dopamine, and later on, nitric oxide was used for the vasodilation. And in patients with previous dysfunction of the systemic ventricle, milrinone was a drug of choice to be used. In patients who had vasoplagia with high cardiac output and to prevent the poor perfusion, vasopressin was the drug of choice. Volume replacement was done using 5% albumin. And for anticoagulation, patients received warfarin, or they received antiplatelet aggregation with aspirin, which was given as per the weight demanded. And before discharge of each of these patients, echocardiography was performed to ensure patency of the Fontan fenestration. Once the patients were discharged, they were followed up by either inpatient clinical visits or by a telephonical visits, which included a questionnaire, which also asked about or looked at the saturation level at the last clinical visit and the need for any reoperation. Let's come to the results of the study. So the main table, which talks about all the results, will be shown in the subsequent slides. But over here, I'll be talking about some of the main points that I would like to look at here. So the study in total included 104 patients. The mean age was 8.5 years plus or minus 4 years. Mean weight was 25 kilos plus or minus 11 kilos. The preoperative systemic ventricular ejection fraction was 64%. The pulmonary arterial pressure was 16 plus or minus 3 millimeter of mercury, and the Magoon's ratio was 2, respectively. The end diastolic systemic ventricular pressure was 13 plus or minus 3 millimeters of mercury. The pulmonary vascular resistance index was 2.1 Woods units. And the most common preoperative diagnosis which required this fenestrated Fontan was tricuspid atresia. However, I will also tell you the other diagnosis which required the fenestrated, but the most common preoperative one was, or indication for this surgery, was tricuspid atresia. Preoperative saturation for the patients who were undergoing a Fontan was ranging between 77% plus or minus 11%, and 95% of the patients who underwent the fenestrated Fontan here at this center had a previous cardiac surgery, which could be anything from a banding to a Glenn or a BT shunt. So 56% of patients, 53% of patients underwent a Fontan operation on a beating heart. Extracardiac conduit was used in 95% of the patients. 1 patient had an intracardiac repair, and 4 patients had an intra-atrial Fontan procedure. Now coming to the further results. So these were what were the initial findings. So amongst in the observations of these patients, 18 patients, which amounted to 17% of patients, had low cardiac output in the pediatric ICU. The chest tube duration, the mean chest tube duration was 8 odd days, and 7 patients developed chylothorax. No patient required a permanent pacemaker after the operation. However, 3 suffered a transient neurological event. 5 patients, which almost 5% of the patients, died before the 30-day follow-up. The most common PTFE graft size used was 16 millimeters, followed by 20 millimeters. So this is the table which shows, as how it is mentioned in the paper, about what are the results, what all they looked at. And as I mentioned earlier, tricuspid atresia was the most common preoperative diagnosis. However, patients with single ventricular physiology, patients with pulmonary atresia, were also diagnoses which required this surgery. And as I mentioned earlier, 95% of these patients had a previous cardiac surgery, and they included the Glenn, banding, systemic to pulmonary shunt, and even there was 1 patient who even had a previous Fontan. The PTFE graft sizes, as I told you earlier, so 16 was the most commonly used size, followed by 20. The post-operative events, There were 3 patients, as I mentioned, who had a transient neurological deficit. And the saturation on discharge ranged between 77 to 88, so around 84%. And on follow-up, the percentage of saturation was 85%. Now, coming to the mortality analysis of these patients. So preoperative characteristics, which we used to look at as high risks for Fontan, and they included, older age of the patient, the pulmonary vascular resistance index of 2.8 Woods units, and systemic end diastolic ventricular pressure of 13.8 millimeter mercury. They did not amount to a significant statistical, evidence. However, in these 104 patients who were studied, what was noticed was high preoperative pulmonary artery pressure of 21 plus or minus 3 millimeters of mercury had a statistical difference as a risk factor for mortality. And regardless of the statistical significance or insignificance, complex conotruncal anomalies were always considered as risk factors for mortality. Now, amongst the perioperative characteristics, which could be looked at as a cause for mortality, prolonged aortic cross-clamp time, use of a 22 millimeter, a little more longer graft, and onset of renal failure requiring dialysis reached statistical significance for mortality. Mortality was also caused by infection in 2 patients, severe neurological event in 1 patient, and early Fontan dysfunction in 2 patients. The mean follow-up time was of 52 months, and the overall survival was 90% at 10 years. And during the follow-up, patients were classified based on the Ross heart failure classification into class 1, 2, or 3. So as we all know, class 1 are those patients who have, who can live normally without any issues. Class 2 patients are those who have issues when they or desaturation or any difficulty in breathing when they do strenuous activity or any exercise. And class 3 refers to those patients who have this breathing difficulties, which is present even at rest. So during the follow-up of these patients, 86% of patients were in functional class 1, according to this classification, with around 87.5% arterial oxygen saturation. So as we know, we had divided the patients, the group of patients, into those who lived in a lower altitude and a higher altitude. So the lower altitude group, that is the group 1. So 88.4% were assigned to Ross class 1 after the surgery, whereas the higher altitude patients, 84.2% of patients who lived in a higher altitude still had no issues after surgery, after the fenestrating surgery, and were assigned to Ross class 1. So what we can see is it is almost similar. The findings are almost similar in the group 1 and group 2, irrespective of the altitude in which these patients were post-operatively or permanently. So what are the comments once we come to the end of this discussion? So a Fontan operation is in our days considered to be a safe procedure because there have been multiple studies. Surgeons are more, they understand how to perform it well and how it can be done in a way so that the post-operative risks can be reduced. The indications have become more extensive in patients nowadays with elevated pulmonary pressure, systemic ventricular dysfunction, and in those patients who also require additional procedures, such as a pulmonary arterioplasty and an atrioventricular valvoplasty. So it is very important, not only in Fontan, but in every patient post-cardiac surgery. But as we are discussing about Fontan, and since we know that Fontan as a surgery is associated with more than with a higher risk of complications. Close follow-up is important for the adequate evolution and early identification of these complications. So there was a case series with the longest follow-up, so around 1,006 patients from 1975 to 2010. So this series has shown that there is an excellent overall survival in patients who underwent an extra cardiac Fontan, and the survival rate was at of 76% at 25 years. And these results excluded patients with hypoplastic left heart syndrome because that diagnosis by itself is related to a decreased failure-free survival with a hazard ratio of 3.8. Now, coming to the physiology of altitude and why altitude was considered as a risk factor, especially when we look at a patient who has a congenital cyanotic heart disease requiring this surgery. So when we look at the normal physiology, so altitude, especially high altitude, has a great impact, as we all know, on the physiology of lung function and other organs. And this is even more so in patients with congenital heart defects, especially in those undergoing Fontan. Studies have shown that the inspired oxygen pressure falls from 150 millimeters of mercury at sea level to 117 millimeters of mercury at 2,650 meters to 100 millimeters of mercury at 3,000 meters. And when we reach the top of Mount Everest, it's the mean pressure of oxygen falls to 43 millimeters of mercury. So in this situation, when a patient is exposed to a higher altitude, the initial response to a newcomer who's not been exposed or not permanently living in these higher altitudes, the initial response that we would notice in these patients would be hyperventilation to compensate for the oxygenation and increased heart rate. Over time, however, the compensatory mechanisms in the body work, and the bone marrow stimulation leads to production of larger number of red blood cells to maintain adequate oxygenation at the same reduced arterial level, which is present at the higher altitude. And acute exposure to high altitude induces vasoconstriction of the pulmonary bed with increased pulmonary vascular resistance and pulmonary pressure. So this is present even in a normal individual. So in a chronic phase, so in these patients who have acutely developed pulmonary vascular hypertension, or I would say pulmonary vascular resistance. So in the chronic phase, over a long period of time, being exposed to hello, am I audible?
Yes, you are.
Yeah. So in the long phase, in the long run, when we look at these patients who are exposed to not patients as per say in people who live in a higher altitude over long periods of time, the pulmonary vasculature is remodeled with an increase in hematocrit and blood viscosity. This causes an increased back pressure, increasing the right ventricular pressure and subsequently affecting the functioning of this ventricle. Chronic hypoxemia also determines the presence of structural changes in the pulmonary bed, such as it causes intimal fibrosis, smooth muscle hypertrophy, and proliferation with remodeling of the pulmonary vasculature. So these changes produce a sustained increase in the resting pulmonary pressure and therefore leads to an increased pulmonary vascular resistance. Now, how do we apply this to patients who are undergoing Fontan? So not only are patients who undergo Fontan at an elevated altitude at a higher risk for late failure, especially when we look at the long changes or the chronic changes of normal individuals who live at a higher altitude. What we would think is that patients who are Fontan survivors at higher altitude would be at a higher risk for late failure, and the exercise capacity would be decreased. Studies at medium altitudes have determined that The other risk factors which would show a Fontan failure or leading these patients to a Ross class 3 or 2 or 3 would be a pulmonary artery pressure greater than 15 millimeters of mercury, a transpulmonary gradient greater than 8 millimeters of mercury, and a pulmonary vascular resistance index greater than 2.5 Woods units. And altitude higher than 2,500 meters clearly produces an impact on the pulmonary vasculature, and this definitely increases the pulmonary arterial pressure. Pulmonary vascular resistance increases, resulting in further increases in the caval vein congestion, but more so in reduced flow, which is more concerning because this increases the ventricular filling pressure. Subsequently, end diastolic ventricular pressure is also increased as seen in the patients in the study. So all patients in this cohort of patients were operated at a higher altitude, which was around 2,640 meters above the sea level. And in the institution, the authors, they established the use of a larger fenestration of greater than 5 to 6 millimeters in every Fontan patient. Why they chose this method was as a measure to deal with the effects of the pulmonary hypertension. And this, they thought when they weighed their risks, would be a better modality to choose in these patients, even if it is at the expense of a diminished saturation in the post-operative period. Because focusing on the effects of pulmonary hypertension was more important, or at least seemed more important in these patients at a higher altitude. So this study showed an in-hospital mortality of, as I mentioned earlier, of 5% with a 90% 10-year survival rate. So in the center, what they've noticed is that the mortality decreased from 16.7% between 2004 and 2008 to almost less than 2% from 2014 to 2019. During the follow-up, 86% of patients, as I mentioned earlier, in the group 1 and group 2 of the two cohorts of these patients. So 86% of them remained in functional class 1. What they found is that there is no statistically significant difference in functional class between patients permanently living at low or medium altitude and those living at a high altitude after the Fontan completion. And on follow-up, 5 patients had low saturation with good hemodynamic features. These patients were taken to the cath lab, and the fenestration was temporarily closed to deal with the low saturation. And what they also did at their center was, if the hemodynamic variables were satisfactory, the fenestration was said to be permanently closed with the use of an Amplatzer device, which improved the mean saturation of oxygen to around 87.5%. The limitations of this study is that it is a single institute experience and its nature is retrospective. And over the course of the 16 years that the study was looked at or done, there 100% would have been changes in surgical and post-operative management of the patients. As I mentioned earlier, initially to deal with the pulmonary artery pressure, dopamine used to be used, and then it used to be nitric oxide. So changes during the course of time also would have shown or given us a different picture or given us different results. And the other limitation that was mentioned is that the follow-up was achieved in about only 82% of patients. What are my conclusions, or what are the conclusions of the authors of the study? Is that Fontan operation at high altitude is feasible with good immediate and long-term results. Extracardiac fenestrated conduit seems to be a good surgical option because it provides an adequate post-operative period. It provides a good functional class, and it also gives a good long-term results, even for those permanently living at high altitudes. Now, regarding fenestration, so fenestration occlusion in highly desaturated patients is a viable option, so which can be done temporarily or permanently, as I mentioned earlier, especially in those patients who have excellent hemodynamic conditions. So this ends my article review for this paper.
Sharmil, are you on?
Hi. Yeah. Yes. Thank you, Alistair, for the very detailed presentation that you have presented. Can I have Dr. Macedo to present a counter view where they have done the study in fenestrated non-fenestrated fontans as compared to the fenestrated fontans at high altitude, and then we'll move on to the panel discussion.
Thank you. Can you hear me there?
Perfectly.
Okay, thank you very much. I just want to take some minutes to clarify some concepts that I think are very important and
Nestor, can you mute, please? Nestor, can you mute, please?
And why do we not fenestrate at high altitude in Mexico City? So first, one thing that I think is very important is to notice that most of the research related to what is called high altitude has been done around the mountain sickness syndromes, which are acute, which is related to hypoxia, subacute and chronic mountain sickness, which are due to hypoxia that induces increased PVR. So acute mountain syndrome is mainly manifested by neurological and gastrointestinal manifestations, is only related to hypoxia, and usually reversed immediately after descending. So it's a relatively benign clinical picture. Then subacute mountain sickness appears usually after several months, is manifested by pulmonary hypertension, and is secondary to increased PVR, which is induced by hypoxia. And then chronic mountain sickness is also secondary to increased PVR, and it's a constellation of manifestations that come as a consequence of long-standing living at very high altitude. So in mountain medicine has used these syndromes to classify somehow arbitrarily but usefully altitude. So high altitude has been considered about between 1,500 and 3,500 meters above sea levels, because at 1,500 meters, the effects of hypoxia, which is high climatization process, start to happen, but there are really mild symptoms. Very high altitude has been considered between 3,500 and 5,500, because at 3,500, severe mountain sickness often happen in patients. I'm sorry. And extreme altitude has been considered to be above 5,500 meters, because there's a progressive impairment of physiologic functions that outstrips acclimatization, and actually living at that altitude is almost not present. So, but common practice has been to talk about high altitude above 2,500 meters, only because very few people present any kind of symptoms below this level. But the level of high altitude has even been brought down to 1,500 meters above sea level, just because there's some acclimatization process that starts to happen at this altitude. But something that's very important is to notice that hypoxia and hypoxemia are not the same as increased PVR. And this has led to some confusion in the literature. For example, when we review this article, it says that mean prevalence of chronic mountain syndrome is 5 to 10% among the global population who reside at altitude higher than 2,500 meters. This is pretty scary, particularly for those who live at these altitudes, because we don't see that often this at our altitudes. But when we see the reference and we go to it, what we really see that it's established in the paper is that establishing better definitions of high altitude related illness is important for the millions of people who live above 2,500 meters, and that it is estimated that up to 5 to 10% of high altitude inhabitants may develop chronic mountain syndrome, but there is no reference at all. And again, it defines it as a clinical syndrome that occurs to natives or long life residents above 2,500 meters, but no reference. So it seems that this limit has just been set arbitrarily, but with no data regarding it. What has really been shown is what happens regarding pulmonary vascular resistance. So there's articles that show that at these altitudes, 3,450 meters above sea level, there's a rapid increase in pulmonary pressure. And also in the first studies by Peñalosa, he reported pulmonary hypertension at these very high altitudes, 4,540 meters above sea level. But the same author, and this is very interesting, making a review of many papers, noticed that pulmonary hypertension in cities, this is measured by echo, just starts to be noticed above 3,000 meters. But interestingly, in cities below 3,000 meters, like Mexico City and Colombia, pulmonary pressure by echo has been shown to be normal. So, and this is supported by some animal studies that have concluded that hypoxic vasoconstriction appears only when alveolar PaO2 drops down to between 50 and 60 millimeters of mercury, and that happens precisely around 3,000 meters above sea level. So we can say that the effects of altitude are really a continuum that starts at 1,500 meters above sea level with some acclimatization, that's some physiological responses like increased heart rate, increased diuresis, is just to adaptate to this relatively high altitude. And then at 2,500 meters, some patients, but really very few patients, as we can say people that live at this altitude, really develop acute mountain syndrome. But acute mountain syndrome is related to hypoxia, not to increased PVR. And then above 3,000 meters, some patients, but not all, start to develop subacute and chronic mountain syndrome, which is indeed related to increased PVR. And then above 5,500 meters, it's almost impossible to live because of the high PVR and all the consequences that hypoxia and increased PVR brings to a patient. So we at the Instituto Nacional de Pediatría in Mexico City, we started to do the Fontan procedure in 2001, initially fenestrating it because it was traditional to fenestrate at these altitudes, but we started to notice that the preoperative PVR and pulmonary pressures were normal. So we gradually abandoned fenestration as a routine strategy. And in 2015, we started to do the procedure at another center, which is located also in the Mexico City Valley, but at higher altitude at 2,691 meters above sea level. And this is the paper we published with this experience. So most of the patients were operated at 2,691 meters above sea level. The median PVR was normal, as we had already noticed for many years, 1.7 units. PA pressure in patients with Glenn, previous Glenn, was normal at cath and even lower during anesthetic induction. PA pressure pre-extubation was normal and even lower after extubation. We had an 80% rate of OR extubation and a very low, well, a low mortality, I would say a low mortality in hospital mortality, not a 30-day mortality. This is an in-hospital mortality, which is very important, which was at 2.5%, only one patient. Chylothorax, 10%, just similar to other reports. And the oxygen saturation at discharge was 90%, which is higher than what we had observed before we routinely non-fenestrated the patients. Then a year ago, we published another paper, early extubation at high altitude with an 81% rate of early extubation. So another important thing, which is different to PVR, is what happens with hypoxia. And it's interesting to notice that even at 3,750 meters above sea level, saturation is still 92%. So what really happens at our altitudes is that we are close to the descending part of this hemoglobin dissociation curve. And that what that means is that in all our patients, not only the Fontan patients, we notice some desaturation for a few days longer, perhaps, than at sea level, because the lungs are usually more edematous and they tend to recover a little bit later. But there's no influence in PVR, only in the levels of oxemia. So in our study, we found normal PVR preoperatively, normal mean PA pressure in 30 patients with previous Glenn, normal pressure in the Fontan circulation after surgery. So we didn't measure PVR, but having normal pressures after the Fontan circulation is an indication that PVR most probably is normal. And we have similar short-term outcomes of non-fenestrated Fontan to those informed at sea level. It's interesting to, if we discuss about fenestration, it was described 30 years ago for high-risk patients. So patients with elevated PVR, PA branch distortion. But there's something that really calls my attention. Why ventricular dysfunction, AV valve insufficiency, single ventricle outflow tract obstruction? In my mind, if we have this kind of dysfunction on the single ventricle, a fenestration would not be helpful because the fenestration would have an impact on the direct flow from the vena cava and from the pulmonary veins. So there was some, I think, misconception regarding fenestration from the beginning, but it was adopted for most patients in an era when mortality was higher and postoperative management was different, unrestricted fluid and non-early extubation. And perhaps during the first days after surgery, it used to be useful. But with the years going by, the immediate postoperative results constantly improve, probably due to modifications in surgical, anesthetic, perfusion, and intensive care techniques. And then many centers have questioned real benefits of fenestrations, and even some centers have abandoned its routine use. High altitude has been assumed to be a risk factor. But what is high altitude? Probably PVR is normal under 3,000 meters. So high altitude between 2,500 and 3,000 meter should not be where most of the centers that do congenital heart surgery at what we call high altitude are located, probably should not be considered by itself a risk factor and an indication for fenestration. And only above 3,000 meters, PVR perhaps starts to really increase, but only a small number of cities are located at these altitudes. So previous studies have shown that moderate altitude probably is not a risk factor, but certainly the limit could be taken higher, probably to 3,000 meters above sea level. So in conclusion, we can say that our results do not solve the dilemma of fenestration versus no fenestration. They only show that PVR is normal at altitudes around 2,691 meters, which is our highest altitude in Mexico City, and probably below 3,000 meters. And that the same considerations should be done then as at sea level regarding Fontan for fenestration or non-fenestration, but altitude should not be considered a risk factor, at least altitudes below 3,000 meters. Outcomes of the non-fenestrated Fontan altitudes up to 2,691 meters are comparable to outcomes at sea level because PVR probably are normal, and management should not differ from that at sea levels. In cities considered to be at high altitude, but under 3,000 meters, like Mexico City and Bogota, fenestration has been used, but without any evidence to support its routine use. And considering the effect of hypoxia at high altitude that I already mentioned, a non-fenestration could even we think, be a better option. These results can be extrapolated, of course, to higher altitudes, and probably in La Paz, which is located at 3,600 meters, it would not be wise to perform a Fontan procedure, but no clinical studies have been done at these altitudes. But to generalize the term high altitude to cities located above 2,500 meters limits our possibility to individualize the management of patients undergoing the Fontan procedure. So that's the way we see things at high altitude for Fontan. Thank you very much.
Excuse me. Thank you, Alexis. So maybe we can stop the share. For our audience and for our panelists, we're going to be going to 30 minutes after the hour. Dr. Sandoval will have the last word since this is his paper, so I'm curious to see how he responds to some of Alexis's comments. And I wanted to just mention one thing I find fascinating, is the mindset that we all come into the notion of fenestration with. So some people come into the whole notion of fenestration with the two words in front of it, have to, that I have to fenestrate, as though that is a failure or a worse outcome. And I come into this the other way around, and that is that I can't fenestrate. That I can't fenestrate because there are pulmonary arteriovenous malformations, for example. I have been, as an intensivist, strongly in favor of doing a fenestration in all patients, only for its short-term benefits. The original thing that Nancy Bridget had done with Dr. Castaneda was to close it on discharge from the hospital. So in fact, there is a fair amount of data of how it works in the short term. I don't know of data at altitude, and I would love the speakers here to study that and give us that information as we move back forward with the next steps. Fascinating papers. It's great to see that things are still evolving. And I'm going to turn this back over to Sharmil, who'll introduce my good friend Dunbar, and we'll go from there.
Yeah, may I invite Dr. Dunbar Ivy, whose primary interest has been pulmonary.
I think we lost you, Sharmil.
That was a good enough introduction, though. So hi, everyone. I'm Dunbar Ivy. Thank you, Sharmil.
I'll just say in front, Dunbar. Dunbar is a dear friend, chief cardiology at Children's Colorado in Denver, which for the United States is very high. It's at about, what, 1,760 meters or so?
1,600 meters a mile high, yeah.
1,800. Okay, so this will be sort of a different perspective. Dunbar's been studying pulmonary hypertension and its management for decades. So I'll turn it to you first, Dunbar. Thank you.
Thanks very much, Gil. And I'm really excited to see the results from Bogota and from Mexico City. As Gil said, we're sort of at moderate altitude, but one of the highest center in the US. And so our experience is slightly different. We have tried to study this and compare with other centers. So with GLE, we looked at our bidirectional cavo-pulmonary anastomosis patients and our Fontan patients and compared them between Toronto, Edmonton, and Denver. And I think, to be honest, a little bit to our surprise, we found that the bidirectional cavo-pulmonary failure and the Fontan failure rates at those three centers, of 100, about 700 meters and 1,600 meters were very similar. And likewise, the pulmonary artery pressure and resistance measurements pre-Glenn, pre-Fontan were very similar. And so the failure rates were about the same. I believe Alistair mentioned some of the cutoffs that we found, and that was a mean pulmonary artery pressure greater than 15 millimeters of mercury, pulmonary vascular resistance greater than 2.5 indexed units were risk factors for worse outcome. And I found this interesting comparing this with the papers because many of the patients who did well and were considered very good outcome had a mean pressure of 16, which for us would have been slightly high risk. And the other difference that I noted was the age of the Fontan, which was at about 8 years when we perform ours, usually at closer to 3 years. Just a brief comment, we don't always fenestrate, but I would say more than 50% of our patients do fenestrate if they have a slightly higher risk. But I also agree with Gil. I think that's more for the short-term benefit of decreasing effusions, getting the patients out sooner rather than as an absolute necessity. We don't use nitric oxide unless the patient has desaturation, and we don't use pulmonary vasodilators normally, such as sildenafil, unless the patient has a prolonged pleural effusion or chylothorax. So I think, the initial phases of the Fontan palliation, the Glenn and the initial Fontan, well, the first stage and second stage, we don't really see much difference. And interestingly, maybe a protective effect, meaning we rarely see pulmonary overcirculation in our hypoplastic left heart syndrome patients. So there may be a slight benefit, but yeah, I think the studies that need to be done is the fuel study was in older patients. We really are unsure about the younger patients perioperatively, and then the decision about fenestration is ongoing, as Gil said. So thank you for having me.
Ambar, thank you. Sharmil, are you back? Is your power ready to go?
I'm back.
Good to see you back.
Yeah, I had a power loss issue, so that's it. Anyways, may I invite Dr. Mark Gavilic, who has done a lot of work with the Fontan physiology. May I have a comment from him regarding the Fontan physiology at the high altitude, as well as what he thinks about the fenestration versus the non-fenestration physiology.
Mark, you're muted. I would love to hear you comment also about the use of pulmonary vasodilators short and long term, since this is something you and Dunbar have been studying for a long time.
Yeah. First of all, my congratulations to the people from Bogota in Mexico. I mean, what they have shown is actually that you can indeed overall perform a good Fontan circulation in the majority of the patients. And I think that is a very important take-home message. On the other hand, the question I was really interested in is what the title of the article actually suggested. Does it make a difference whether you do it at sea level or at higher altitude? And we can discuss yes or no what the altitude should be. And there it is. The article from Bogota did not really answer that question. For instance, they make the cutoff patients above 2,500 meters and below 2,500 meters, but they never mentioned in that article how low they really went. I mean, if they went only to 2,400 meters, who cares? But if it was at sea level, that would be a big difference. I always keep my take-home message would be that also knowing the rest of the literature, there have been reports, and I think one of those reports was from the people from Colorado, Denver, where a lot of Fontan patients moved up to high levels, and they saw within a couple of months after the move that there were problems coming up in those patients. I'm aware of two reports. One patient, for instance, that noted that if it was flying from West Coast to East Coast or back, each time that patient did it, and that's about a 4-hour flight, that PLE would exacerbate in that patient. Yeah. Another report of a patient that when it moved up and down, and they did it 3 or 4 times, I think, in the paper, that if they went from sea level to high level of 3,000 meters, also PLE, for instance, would aggravate. Coming down, it would again ameliorate. For me, the take-home message is there that if you are a borderline Fontan, probably if you go up at height, it may change 5 or 8% or something like that in pulmonary vascular resistance and in output or in congestion. And that in the majority of the patient, it doesn't matter. But in a subset of patients, it may make a critical difference. Yeah. And whether that difference is then big enough to recommend everybody leave the mountains and go down to sea level, a completely different question. Now, we have to also compare that with, some people speak about long-term results in Fontans. And I think we all agree that we see a lot of trouble coming up after 20, 25, 30 years. And so for me, long-term, that would be 60 years, 70 years. And nobody has good data on that yet. And whether that 5% change may make a difference for after 20, 30, or 40 years, that still needs to be demonstrated. And I'm afraid that there probably the answer will be more in the advantage of the lower the better. But I mean, that point still has to be made. Now, the other question then that was raised by Jill about the fenestration, theoretically, there are advantages of leaving a fenestration or making a fenestration, whereby you limit the congestion and you increase the flow. Limiting the congestion will be probably very important with the liver disease that is associated with things. And the output, I think I'm a firm believer that being able to give sufficient preload to the ventricle will slow down the diastolic compliance problems. Stretching the ventricle with exercise or with sufficient volume appears to be important. And so the question of the fenestration is just like a candle. Do you want a candle to burn hard, or do you want it to burn long? Yeah. And when you're young, you want the candle to burn hard. You want to see a lot of light and see what's going on. Once you get a little older, you want the candle to burn long. And then maybe you will regret decisions you made as a young person. And that's probably going to be the discussion. Do you want to have, I'm a firm believer that if you close a fenestration, in the short term, the patient will do better. They feel better, they can do more. But in the long run, probably problems like liver disease and diastolic dysfunction may appear sooner. I'm a firm believer that the liver probably will do that. So it's the eternal question: do we go for quality or do we go for quantity? And I think the opinions will. I mean, that's where probably most of us at one point will disagree. Did I answer those questions a little bit decently, Jill?
I'd just like to add, I agree with Professor Gewelig about the long-term complications of Fontan. Angie Yetman wrote a paper in Salt Lake, and in her adult congenital practice, there was quite a drop-off in the quality of life of patients, and even in survival in the third decade of life. So,
Dunbar, will you comment for the international audience how high Salt Lake is?
Salt Lake, I believe, is around 4,500 feet, so probably around 1,200 meters. So a little lower than Denver is.
And a lot lower than the two presentations today. So it will be.
And a lot lower than the two presentations. Exactly. So I agree with you. I think, we've discussed short term or medium term, but in the long term, I think even at moderate altitude, there are effects on the Fontan circulation.
Well, to finalize my point, we know that there are, even in the best Fontans after 30 years, we see major problems occur. And most likely the 5% change in pulmonary vascular resistance or whatever may make those trouble appear sooner. And we don't have sufficient data yet to say yes or no. But I mean, especially in the borderline cases, the ones that develop PLE, yes, no. I mean, that are living laboratories of the experiment. What does high altitude do to you? And so if you're borderline, I think it's probably wise to go low. But that's the opinion of somebody. I am living in the low countries. I mean, the biggest hill we have here is 700 meters in Belgium. So.
Can I have Dr. Nestor Sandoval respond to the comment Dr. Gavilic made that in the two groups, the lower group, what was the altitude at which these patients were placed actually?
Thank you very much for this great meeting, and it's a pleasure and honor to have to share the podium with Dr. Raby and Professor Grilling. Everybody knows here in the audience that you've been reading the most important papers about Fontan circulation, and regardless of the high altitude and comparing the follow-up between 2,500 meters above or below sea level, it was a discussion for the paper, and it's hard to establish the condition of patient living between 2,500 meters and 2,000 meters and 1,500 meters. So we decided that because of the most important publication from the group of Denver from Lorna Road, which established that high altitude and the changes in the oxygen consumption, and it started once you reach the 2,500 meters, we decided to divide the patient in these two groups for the follow-up. And of course, this is different than Mexico. Mexico is 2,240 meters, and we are 2,600 meters above sea level. So I think it's when you see the papers and the results, we have higher PA pressure, we have higher pulmonary vascular resistance index. So our patients are very different, and that's why, as you mentioned about fenestration, we feel comfortable with the fenestration, and you, in some patients, you need to go back and open the fenestration to keep the patient alive in CICU. And I think it's a very important comment from you. Thank you very much for your comment. It's very useful, and maybe Bill Novick, that has been working with us, maybe can have a comment after this discussion too. Thank you very much.
Dr. Novick, you have experience of operating at different altitudes. May I have your comment on this, please?
Yeah, I'd love to. So we have had the opportunity to perform Fontans, what I would call moderately high altitude, between 15 and 2,500 meters. Nestor, in all of the programs that we ran at SHIO, I don't recall that we did any Fontans in those 11 programs, did we?
No, we didn't. We didn't do any Fontan in those.
Yeah. So we've done Fontans in Peru that have gone back into the Andes. Similarly, Fontans in Pakistan that have gone back into the foothills of the Himalayas, and kids in Ecuador that have gone back into the Andes as well. And what we have seen is that those children that had fenestrations performed at sea level, because of where we thought they would be going back, had a significant change in their saturations when they arrived at home. Now, I will have to add that we have two distinct camps in our group, and that is those that do not perform fenestrations either routinely or even grudgingly, that would be me, and the rest of our surgeons. And with regards to early survival that Mark was referring to, we've seen a difference in that regardless of which altitude you come from. Those that do not perform fenestrations, our survival rate or our mortality rate is about 5%. And for those that do, it's 7.7%. Now, I realize, it's a lot of different countries and a lot of different surgeons. But that's pretty much our standard practice. Now, I'd like to just go back for a minute to something that has to do with high altitude versus sea level, and ask Dr. Sandoval if he remembers the child that we did the double patch operation in for VSD, who was in Bogota for the operation. We did the double patch, and his saturations were borderline 89, 90. And when he went home, or to visit his grandmother, maybe that's what it was, in either Santa Marta or Cartagena, his saturations rose into the mid 90s. So, it's been our experience not only there, but also in double patches that were performed in other places where the children went to high altitude, that there is a significant change. I think the partial pressure of oxygen certainly has a lot to do with it. We've seen this, and although the information that I have is highly anecdotal, it's been a reality for us. Thank you. Oh, one last point, Gil. Since the universal availability of sildenafil in 2005 in a number of the countries that we travel to, we have routinely used sildenafil upon induction in all of our Fontans, 3 milligrams per kilogram at induction, and then 1 milligram per kilogram every 8 hours postoperatively for the first week. And the idea behind that for us was to diminish postoperative effusions. Thank you.
Dr. Macedo, I see your hand up. So could you please go on and your comment?
Yes, I just wanted to clarify some points. First, most of our patients in our series were operated at 2,691 meters above sea level, 80% of our patients. So it's even higher than Bogota. That's the first point. The second point is that if we look at the literature, nobody has shown increased PVR at these altitudes. And that's very important. We assume it's high, but nobody has really documented it. It has been documented above 3,000 meters, 3,500 meters, 4,000 meters. That has been documented, but nobody has documented it at these altitudes. And these altitudes are where most of the centers working at really high altitude are, like Bogota, Mexico, some places in China. So I think that just assuming that PVR is high at this altitude just prevents us from acting in another way that can be helpful for the patient. Like, for example, not fenestrating them. Patients, what we do know is that at these altitudes, there is hypoxemia. And hypoxemia, yes, can be a problem in the immediate post-operative period. And then another thing is important to notice is that one thing is where we operate the patients and where they go to live. So we can operate a patient at the Mexico City or Bogota altitude, and then it wouldn't be wise for them to travel to 3,500 meters above sea level. But because there, of course, PVR might already be high. And if we go to the Himalayas, the PVR is really high. But I think we need to focus on only the centers where cardiac surgery is being done at what we call high altitude. So that's the only things I wanted to stress. Thank you.
Right. With that, I would invite Dr. Reena and Dr. Raja Joshi for a comment. There are a couple of things that are of interest to me, since I know that we are operating mostly at the sea level. What is your take, Dr. Joshi, regarding the fenestration versus non-fenestration? And the second question that I have in mind, which has arisen after Dr. Gary made a comment that some of the patients who get operated at the lower altitude, when they go to the higher altitude, they still have problems. Since we have patients who come from a higher altitude to us, get operated and go back, what has been our experience with respect to such patients?
Thank you, Sharmil. It's an honor to share the podium with the likes of Dr. Gary, Dr. Wernovsky. I'll tell you, we work in Delhi, so what's not killing us is the height, it's the heat which is killing us. The thing is, we do have very small pockets of places like the region in the northern part of our country called Ladakh. It's a beautiful place, like most of the places. We've spoken about Bogota and Mexico City, but from Ladakh, when we see patients, they come with intense polycythemia, which is probably one of the most common compensatory mechanisms which these people from those areas have. But to be honest, we have not found those people to have a high pulmonary vascular resistance. It's not a very large number of patients. We've seen almost maybe 5 or 6 from that area who have come to us for a Fontan. And these patients, we have found out that their PVR has not been too high. Now, I come from Dr. Roger Mee's lineage of thought, and I think Dr. Novick is an example of the same kind of thinking. Fenestration is very difficult from our unit to get by. We don't fenestrate regularly. We are non-fenestrating kind of unit. We haven't found too much of a disadvantage with effusions there, which seems to be the biggest short-term advantage that fenestrations offer. Dr. Gevelig throws a light on long-term lasting of the candle, and I'm still to get across to that sort of problem in the follow-up. But when they go back, people who have gone back after a Fontan, they do complain of problems related to hypoxia. They do present with problems, and they have to be brought back sometimes to Delhi. So that's our very small experience in India from the people of the region of Ladakh belonging to that area. Now, the important thing is that selection criteria is probably common for both these people. For people from the normal height regions versus the whatever number we want to give, 3,000. Ladakh is somewhere around 3,000 meters. It's about 3,000 meters, so it's higher than both those places. But if you look at the selection criteria, we have not changed our selection criteria for either of these two group of patients. Same PVR goes. Selection criteria is still the same. 21 plus minus 3 in Dr. On the report from Mexico City. That seemed to me to be a bit on the uncomfortable side for selection for Fontan. And that would not go down well in my part of the practice. I don't know. I would like to have some comments on that. So that's my take on the situation. Does fenestration have the common the need for fenestration? Is it common in places where hypoplast is a more significant portion of the chunk of Fontans? Because in India, hypoplasts are not a large chunk of the Fontan population. So is that something that is more often used in the Western literature?
You used the words I was hoping you would use, Raja, which is the need for fenestration. The way I think about that is, do you need to use a Lecomte for the arterial switch? Well, you don't need to, but it's a good idea. So I think about it frequently. You don't need to do a fenestration, but is it a good idea? I'm going to close up with a few comments. Mark, did you have your hand up, or were you just waving your hand? Okay. Bill, are you having your hand up? Let me see. There's a few people that are going through that. I want to be sure we have a little time to close. Bill, and then Alexis.
Just one quick question to Nestor. Nestor, your center is a national sort of referral center, and you've got the Santa Marta mountain chain, where you've got patients that are over 5,000 meters coming to you, I would imagine. Have you segregated out those patients that come from, if you will, extreme high altitude?
No, because we haven't seen difference when you studied them at this altitude, and but we see very old patients. And Dr. Mark Gulligan comment, maybe the age could play a role in this increased pulmonary artery pressure, or maybe because the chronic thromboembolism increases the PA pressure. I think this could be a risk factor, but we haven't studied yet. But once they arrive here, even from a higher altitude, we don't find any difference in PIP or pulmonary vascular resistance.
Just one comment. I think it's important when we analyze Fontan preoperative data, we can have high pulmonary pressure if the patient, or what we consider high, if the patient has a PA banding, which is not unusual in our countries. So that's not abnormal. What really needs to be analyzed is what's the pressure on the gland circulation. So mixing these pressures can be a little bit confusing. And answering the other question about the Norwood, yes, I guess we do some Norwoods in the series. There's one Norwood, but I think the problem is not mostly the PVR, but the distortion on the PAs that can arise from the Norwood procedure and all the reconstruction. So perhaps we need to be careful not to fenestrate those patients, but not because of PVR, but because of distortion of the PA anatomy. Thank you.
Bill, this is Nestor. This is a great paper. I really enjoyed reading it, and I think it's stimulated a ton of discussion. And as the first author of that paper, you get to say the final words before I wrap things up. So, Dr. Sandoval.
Thank you very much. I think that is the only paper with all the patients are operated at the same altitude, higher than 2,500 meters. And this is our protocol, and based on our experience and on our data, we have to set up a protocol. So as you mentioned about fenestrations, we have to do it because we feel very comfortable for the management after the operation. What is going to happen in the future, we can close the fenestration if the patient is doing with a bad, is having a lower saturation. And I think this is what we have, and this is the protocol that we have based on the study from everywhere around the world. So thank you very much. I really enjoyed and I learned a lot from you, and hopefully I can participate in other presentations. Thank you, Jill, and see you in Washington.
I look forward to it. I think let me see if this is on.
That is on.
Or are my slides there?
Yes,
okay,
yes,
good.
they are.
Oh, good. I'm just going to close with just a couple of things. I have really enjoyed this, everybody. Thank you all for getting on, and I hope the attendees have opened it up as much, because I had a couple of thoughts I just wanted to close with. This is one of my favorite 2x2 tables that has been modified from a couple of places. But if we look on the left, what we do practice and what we believe is true, and then what we know and what we don't know about what's true, and what we use and what we don't use. If you think about things that we know are true and we use, then we're happy. That's called evidence-based medicine. Things that we don't know and that we don't use are areas of research to move forward. There's certainly things that are known in science but are resisted by people, or it doesn't get to their practice, which is sometimes due to cognitive dissonance. That's holding on to and rationalizing beliefs in the face of new data. But this is what this webinar has made me think about. Things that we don't know are true, but we use. And it could be that they just work. In fact, it is true. And it could be that we're just wrong. And we have to sort of know that the things that we do aren't always, they may not hurt, but they may not help. And therefore, I would encourage everyone who's listening today and on the call to keep an open mind that what we think is true may not be. Can we ever agree? Many of the talks, especially my own, will frequently say, I always do this, or I never do that, or we routinely do that. So today we had more questions than answers. I was typing these as the talks were going along. We're not 100% sure on patient selection or pre-treatment. A lot of talk about intraoperative fenestration, who and when to close. Is it an always or a never thing? Almost certainly not. How do we take a linear variable like altitude and break it into categories? That's always a problem. We talk about a CVP, for example, above 10 or less than 10. In a continuous variable, that's somewhat arbitrary. We've had things like postoperative management. We haven't talked about supplemental oxygen in the subgroup of patients. So really, this has given me so many ideas for future academies. One certainly is to debate Dr. Novick on the routine use of fenestration. So you and I may have a chance to, do that in the future. I would encourage people to log on. Oh, let me see. I think I have one more slide here. I would encourage people to log on to, see if this comes up here, to the World Congress page. There are opportunities for you to write in ideas for the program. visa letters, as I talked about before. You can scan that QR code or use the World WCPCCS2023.org. And that'll give you a link to that. And I want to thank Dunbar especially for getting up early on the mountain time here in the US and people staying up late in India and everywhere in between. This has been just a terrific journal club, and I appreciate it. And Nestor and Alexis, again, congratulations on your great work in a very complex group of patients. Really is terrific.
Thank you.
I have one question.
Are we starting to debate now, Bill? Or
yeah, no, one question for the Congress. No, we're not going to start the debate now. Who's in charge of the exhibition hall for the sort of NGO village? Is that
Dr. Dr. Jeff Jacobs? Yep.
Okay, thanks.
Okay. Any other questions? Dunbar, you have a question? You're saying goodbye.
Goodbye.
Everybody have a great day. Mark, thanks for joining us. Rena, Raja, thanks for joining us. Okay.
Thank you.